Good afternoon. I am Nick Rebel, the Executive Director of the International College of Surgeons, United States Section, or ICS-US. It is my pleasure to welcome you to the first episode of our Grand Rounds webinar series. We are pleased to partner with NYC Health and Hospital Harlem in this endeavor and look forward to a mutually beneficial relationship. The International College of Surgeons, United States Section is an ACCME accredited provider, and we are delighted to offer AMA Category 1 credit for this episode. Our mission is to unify surgeons and related specialists to promote surgical excellence for the benefit of all people. And our vision is to advance surgical outreach. Educational activities such as this webinar series are one way that we fulfill our mission and vision. As part of a global society of general surgeons and surgical specialists, the ICS-US is the largest national chapter of the International College of Surgeons. Through the active participation of our members, we are able to provide programs such as today's webinar. We are also actively looking for new members who are interested in becoming active in our organization, which prides itself on providing a platform for all qualified members to participate in leadership roles at a pace that fits their level of commitment. Visit our website, FICS Online, for more information. It is my pleasure to now introduce our host and moderator of today's program, Dr. Sharik Nazir. Dr. Nazir is a general bariatric and trauma surgeon who became a fellow of ICS in 2015. He is the treasurer of the ICS-US and will be the president of our section in 2025. At the international level, he is currently an ICS World Governor. Dr. Nazir currently holds the position of Director of Bariatric Robotic Surgery at NYC Health and Hospital Harlem and is an assistant clinical professor at Columbia University. And now,
thank you, Nick, for my introduction, and thank you, International College of Surgeons US Section, for partnering with Bariatric Department of New York City Health and Hospital Corporation, Harlem Hospital, for our newly introduced bi-monthly bariatric robotic grand rounds. It is my absolute pleasure to welcome you all in the first episode. We gather today voluntarily and virtually to engage in an enlightening and informative discussion focusing on the latest development and research and best practices in the field of bariatric surgery. And as we navigate through the digital platform, we embrace the opportunity to connect with healthcare professionals, experts, enthusiastic from across the United States and the world. The Bariatric Department of Harlem Hospital has a long-standing commitment to provide exceptional care for patients struggling with obesity and related health issues. We are fortunate to have 3 experienced bariatric surgeons in our program. We have a medical doctor, we have PAs, nurses, MAs, receptionists, and also we have obesity medical director who works tirelessly to offer compassionate and personalized care to optimize and improve the lives of those affected by obesity in our Harlem community. And we are very privileged to have with us CEO Mr. George LeConte, CMO Dr. Maurice Wright of Harlem Hospital, who has graciously taken time to be part of this important event. Firstly, we are honored to welcome our CEO, Mr. LeConte, who has wealth of experience on healthcare leadership. Mr. LeConte has been instrumental in delivering the vision and mission of Harlem Hospital. Under the guidance, the hospital has achieved remarkable milestone in patient care. He has continuously exhibited the community engagement I see in day-to-day practice and healthcare innovation. Mr. LeConte, we'll be grateful if you can come and give us inaugurating talk.
Thank you, Dr. Nazir. Good afternoon, everyone. All right, it is my esteemed pleasure to be a part of this. My name is George Lacan. I am the CEO of NYC Health and Hospitals Harlem, a proud level 2 community hospital, level 2 trauma community hospital in the heart of Harlem. We serve the community of Harlem, the Upper West Side, and also part of the Bronx. As you know, obesity is a problem, not just in Harlem, pretty much worldwide problem. And is something that we're working very diligently in terms of helping our community face and also reduce some of these struggles. It is my esteemed honor to be a part of this. I appreciate this partnership between the International College of Surgeons, United Sections, and Harlem Hospital. And this is a partnership that we hope to continue for quite some time. So I want to thank you, Dr. Nazir, for putting together this really wonderful partnership. And I look forward to continuing this. Thank you.
Thank you, Mr. Lecourt, for your gracious talk and time. And we'll be doing more in the future. And I'd like to invite and very, very delighted to have our Chief Medical Officer, Dr. Morris Wright, who I know him from my residency days. And he has been working for several years at Harlem Hospital and is bringing wealth of medical experience and clinical leadership to the bariatric department. And with his deep understanding of the challenges faced by patients with obesity and a passion which he's having for improving the healthcare outcomes, Dr. Wright has been instrumental in shaping the department's strategies and initiatives. Thank you, Dr. Wright, for your time, and welcome for your inaugural talk.
Thank you, Dr. Nazir, and welcome to the International College of Surgeons, United States section, to community of Harlem. We are prevalent of metabolic disease is extremely high. We have over these many years looked at bariatric surgery as one of the solutions that we have brought into the armamentarium of how we take care of our patients. And we have gone quite a way. It's been an unbelievable, I'd say, progression in what we've been able to do to address many issues. The health benefits from weight loss alone on the on the improvement in cardiovascular risk factors, fatty liver disease, diabetes management, reduction in mortality are all being realized here. We have, with the help of our bariatric surgeons and our weight loss physicians, put together a program here which really spells out the excellence in bariatric surgery as a treatment option for these patients. When you just look at the reduction in mortality alone, it is incredible. I mean, for those overall from 40 to 23%, and within our domain, looking at cause reduction, all-cause mortality reduction from about 60% to 30%, it is no wonder that we have really worked hard to put together an excellent program here under Dr. Nazir and the Department of Surgery. I have to say that over many years of being in healthcare, I didn't ever expect that the day would come when we would see various teams, for example, endocrine, the weight loss program, and bariatric surgery hand in hand to address an issue. And for that, I am very grateful for this community and for all the patients across the world that benefit from this service. I want to thank all involved in the program here and worldwide in what you do to address the issue that we face. And it is such a problem worldwide that I can just imagine as time comes on and as the literature continues to be supportive more and more, that we'll see even better outcomes. So with that, I'm looking forward to this section. And again, thanks to all involved, and especially to Dr. Nazir for leading this. Yes, we've known each other for many years. Dr. Nazir, you made me feel old. I remember when you were an intern. But again, thanks for all you do. Thank you.
Thank you, Dr. Wright, for gracing this occasion. And I'd like to thank the CEO and CMO who embodied the shared vision of providing exceptional care and advancing the field of bariatric surgery. You guys have excellent leadership, guidance, and unwavering support, which has been instrumental in the success of our department. Now, it's my great pleasure to introduce our esteemed speaker for today's talk, Dr. Alex Barkan, who is nationally recognized expert in the field of bariatric surgery. Currently, he's the Director of Bariatric Surgery and Vice Chair of Surgery at Richmond University Hospital, Staten Island, New York. He has published numerous influential papers in the top-tier medical journal, shedding lights on the mechanism of underlying metabolic surgery and its outcome. In addition to scholarly achievement, Dr. Barkan is an exceptional clinician, and I've known him for long years, an educator. So please join me in welcoming Dr. Alex Barkan.
Thank you. Thank you, Dr. Nazir, for inviting me to give this talk to the International College of Surgeons. And thank you for the distinguished conference members to allow me to speak today. I'm going to talk about metabolic updates in bariatric surgery. It's going to be a combination of medical and surgical talk since this is an emergent combined treatment modality. As you're aware, obesity in the United States is on the rise, particularly severe obesity. Up to 22 million Americans currently qualify for weight loss surgery in the United States. What causes obesity? Well, we know what causes it, and we don't know what causes it. We do know that genetics plays a role. We also know that the environment plays a role. But interesting things like air conditioning can play a role as well, because people in the past did not have air conditioning. They sweated in the hot weather, and that allowed them to lose more weight. Well, today they have air conditioning, and so sweating is less of a necessity. Particularly, the common mosquito can be a cause of obesity as well. Children will play less outside during the summer months if there are more mosquitoes out, causing them to have less physical activity and potentially becoming obese. So, although it's funny, some of these causes, but they can be relevant, and we sort of never thought about them in the past. We know genetically, studies that have been done for many, many years show that homozygous twins versus heterozygous twins have a higher prevalence of obesity, which points to genetics as being a major cause of obesity. A common disorder, the most common genetic disorder of obesity is the Prader-Willi syndrome. It is inherited from the father. It is a random mutation, cannot be predicted in terms of heterozygosity or homozygosity, but it manifests as hyperphagia, developmental delays, and a mental instability. These children and adults never become full. They can have a full meal and then forage for food in other places afterward. And so some of them who live in group homes have counselors who follow them around to prevent them from eating random things. Another genetic disorder that is not common but is worth talking about because it has a treatment modality. There is a medication called Imcivree that can be used to treat melanocortin 4 receptor mutation. The melanocortin receptor sits on the hypothalamus, on the POMC and the agouti peptide protein to control satiety. Its dysfunction can lead to obesity because it has less response to leptin, which is the most common hormone associated with obesity. As opposed to Prader-Willi syndrome, melanocortin-4 receptor mutation patients are tall in stature, as opposed to short in stature in Prader-Willi. Another rare disorder, but can cause obesity, is the mutation of the actual POMC protein, which is found in the hypothalamus. Its clinical manifestation is the infant is born with adrenal crisis, hypotension, and that it could be a clue that a POMC mutation is the cause of this condition. The hypothalamus has been studied since the 40s with animal models, particularly the mouse, and it's been found that if you cause lesions in different portions of the hypothalamus, you will create either anorexia or obesity. Today we know that the POMC protein and the agouti protein, as well as the neuropeptide Y protein, are those proteins that are actually causing satiety and hunger, controlling hunger and satiety in the brain. Current medications, such as GLP-1s, that we'll talk about further, act on the brain in this area to control satiety. What's interesting is that there is a concept called epigenetics. Basically, the mother, when gets pregnant with the infant, her environment can control what happens to the infant after birth. And there is a mismatch. Basically, if the mother is exposed to high contents of food or very low contents of food, that can manifest in obesity in the infant. So current studies show that maternal weight loss from obesity surgery prevents transmission of maternal obesity to children, which is very interesting and actually adds to the study of epigenetics. Leptin, as I've mentioned, is the most common hormone found in obesity. It is found in the white adipose tissue, and the increased levels of white adipose tissue increase the levels of leptin. Leptin acts on the melanocortin-4 receptor to control satiety. There is a familial condition of a leptin deficiency. This also leads to obesity and is treatable, but these family members are a very small percentage of people who have real genetic leptin deficiency. But leptin is the most common hormone associated with obesity. GLP-1, or glucopeptide-like protein, is now a big player in treating obesity medically. It is a hormone that's produced peripherally by the cells in the ileum, jejunum, and duodenum, but it does act both peripherally on the pancreas, the beta cells, as well as centrally on the hypothalamus. What's interesting here is that the GLP-1 was not known to act centrally in the hypothalamus. Only now, with the advent of new medications, we are seeing that GLP-1 also acts centrally as well as peripherally, and decreased levels of it are found in obesity. Ghrelin is the only peripheral hormone that functions, that is called a hunger hormone. Increased levels of ghrelin are associated with hunger. During sleeve gastrectomy and the removal of the fundus is thought to be a cause of satiety and help with weight loss, because that's where most of the ghrelin is found in the human anatomy. Currently, there is a paradigm shift in the thought process of the cause of diabetes. In the past, we thought that insulin resistance was the cause of diabetes, and so we developed medications to decrease insulin resistance and promote insulin uptake into the cells. But currently, it's thought that that is not the mechanism and the cause of diabetes. It is thought that hyperinsulinemia and the increased release of insulin is what causes diabetes. And so we are developing medications such as GLP-1s to decrease release of insulin and to decrease possibly obesity, as well as the onset of particularly type 2 diabetes. Well, the question really is now, who is eligible for anti-obesity medications? The criteria currently are that a patient with a BMI that has greater than 27 with comorbidities, or a patient whose BMI is greater than 30 without comorbidities qualifies for pharmacotherapy treatment, as well as on top of dietary and behavior modification. What are the current medications available on the market? Well, there's phentermine. It's been around since 1959. Its trade names are Atipex and Lomera. Atipex is prescribed at 37.5 milligrams once a day. Lomera is prescribed 8 milligrams 3 times a day, but its function is the same. Orlistat is a well-known medication. It's been on the market for a long time, but is used currently because of high levels of steatorrhea, but is available over the counter as Ally or prescription with Zeneca. Another medication called phentermine combined with topiramate called Qsymia is also a medication that is available for weight loss, as well as Contrave, which is naltrexone with dipyrion, and liraglutide or semaglutide, which is Saxenda, Ozempic, and Wegovy. Metformin is interestingly used for obesity treatment. Although its results are variable, it is a very safe medication. It does not decrease glucose levels, but can have GI symptoms, and it is used as an adjunct with other medications to help control obesity. Phentermine is basically a sympathomimetic medication that can cause side effects such as increased heart rate, headache, insomnia, and dry mouth. It should be avoided in pregnancy and in patients with cardiovascular disease, as well as glaucoma. Again, it was discovered in 1959, and different manifestations of it have been used for many, many years. In the past, we've heard of fen-phen, which caused cardiac disease and was taken off the market, but current medications are fairly safe with minimal side effects. Phentermine and topiramate, an interesting combination of medications. Phentermine is a norepinephrine-releasing agent. Topiramate is a neurostabilizer used for epilepsy. And so some of these medications, when you're looking at who to prescribe them to, you should look at the history of the patient. The patient who has migraines, headaches, or possibly epilepsy, this medication will help in not only lose weight, but also control some of these symptomatology. What about special considerations? So migraines and seizure prophylaxis is good with the use of Qsymia. Caution: cardiovascular disease, hyperthyroidism, pregnancy, and glaucoma. Also, Qsymia is known to cause nephrolithiasis. So patients who are predisposed to nephrolithiasis, we consider not using Qsymia. What about Contrave, which is naltrexone and dipyrion? Dipyrion is found in Wellbutrin, which is currently used for smoking cessation and mood stabilization. Naltrexone, as we know, is an opioid receptor antagonist. And so patients who are on chronic opioid use for chronic pain, we should consider not using Contrave in those patients. But patients who particularly want to lose weight and also stop smoking, for example, Contrave might be a good option for them. Some of the side effects are headache and nausea and vomiting, which is sort of similar to many medications, but cautions: it should be avoided in patients with opioids, as well as patients who have seizures or uncontrolled hypertension. And special considerations for Contrave are food craving disorders or addictive eating disorders, such as bulimia. Or a patient, again, wants to quit smoking, it could be a good option. What about liraglutide or semaglutide? Well, it's a GLP-1 agonist. We've seen it. We know, everybody knows about this medication. It's everywhere in the news, articles about it. People use it left and right. And so it is an effective medication. The difference between Saxenda, Ozempic, and Wegovy is maximum doses. Saxenda maximum dose is 3 milligrams. It's a daily medication, whereas Ozempic and Wegovy are weekly medications. And it's prescribed to patients who have a history of diabetes and patients who qualify for weight loss. In terms of its caution, patients who have particularly gastroparesis or a history of pancreatitis, although clinically pancreatitis is not common, but patients who have a history of pancreatitis, this medication should be used with caution, as well as patients who have a familial medullary thyroid cancer due to multiple endocrine neoplasia syndrome type 2. In these patients, this medication is not particularly contraindicated, but should be given with caution if they have a history of these things. Special consideration should be given to patients who are diabetics. It decreases the release of insulin, and so can help in control of sugar levels. Some of its side effects are common, such as nausea, vomiting, diarrhea, and constipation, and also patients who are undergoing weight loss surgery who have been placed on these medications preoperatively. These medications should be stopped because it can add to gastroparesis after surgery, which can cause nausea and increased levels. Some studies have shown, or anecdotally, that maybe there is an association with this medication and depression, but we have not seen any randomized studies just yet. So the question is, which medication for which person? So questions should be asked. Are these side effects, contraindications, or drug-drug interactions, such as phentermine and anxiety? If a patient has anxiety, don't use phentermine. If a patient has a history of seizures or opioid disorder, don't use Contrave. Could any of the medications improve another symptom or condition? So phentermine with topiramate or fusimia can be helped in patients who have a history of migraines, and semaglutide or liraglutide can be used in patients with elevated blood glucose. What are some of the practical tips for treatment? Medications should not be prescribed in the absence of behavioral counseling on diet, physical activity, and lifestyle interventions. These things all should be combined in treatment of obesity. You have to assess the efficacy and safety of meds at least monthly for 3 months, and then every 3 months. And the goal is to lose at least 5% of excess weight after 3 months. And if that goal is not reached, you should consider either stopping the medication, increasing the dose, or changing the class of the medication. You want to stop the medication if they're not responding to it. Why 5 to 10% weight loss? Because it's been shown through studies that 5 to 10% excess weight loss can prevent diabetes or decrease its medical problems. It can reduce the need for blood pressure medication, decrease triglycerides, and improve sleep apnea symptoms. Why surgery? Well, because surgery has been around for over 70 years. There's multiple randomized controlled studies, and it's been shown to be very effective. There are 0 to no mortalities with surgery. There are less than 5% major complication rate with surgery. Surgery is effective against diabetes and reduced medications taken, weight, and dyslipidemia. So it improves all of the issues associated with metabolic syndrome. Major studies, including this one, comparing conventional medical therapy for type 2 diabetes versus surgery. There's a randomized controlled study. We looked at gastric bypass, we looked at duodenal switch or biliopancreatic diversion versus medical treatment. We looked at patients whose BMI was over 35, whose hemoglobin 1AC was over 7, and who had diabetes mellitus for over 5 years. And if we look at it, we see that estimated weight loss, surgery, Roux-en-Y, BPD compared to medical, up to 70% weight loss at 2 years, up to 73% of weight loss after 5 years, compared to only 16% of weight loss with medical treatment. What about diabetes remission? After 2 to 5 years, we find there is 0 remission with medical treatment as compared to up to 95% remission with surgery. Patients who relapse with diabetes at 5 years after surgery still maintain a hemoglobin 1AC less than 6.7%, and their sugars can be controlled with diet plus or minus metformin alone. But what about the complications? Well, that's what we're always worried about with surgery. Well, most centers today who practice bariatric surgery are designated a center of excellence by the American College of Surgeons. And so because of that, all their surgeries go into a central database. So there are thousands and thousands of surgeries that are in the central database, and studies that have been developed from the central database, including complications, looked at 150 different factors that can cause issues after surgery. The number one complication after surgery is nausea. Out of 150 factors, nausea is the number one complication. Issues such as deep venous thrombosis or wound infections, reoperations, and even death are minuscule, relatively speaking, to the overall amount of surgery that's performed. So how much surgery is performed in the United States? Well, it's interesting. Since 2011, when data started to be collected, the numbers haven't really increased. As I told you earlier, 22 million Americans qualify for surgery, but only 250,000 in 2018, and only now at about 270,000 yearly operations performed in 2021. You see that number is minuscule compared to those who qualify for surgery. So the numbers haven't changed much in the last few years. And we know several factors why. There's fear associated with surgery, there's access to surgery, there's stigma associated with surgery. Of course, insurance companies decrease access to patients for surgery. And so these are the reasons why surgery has not become even more popular as it should be for those who need it. We know of sleeve gastrectomies, which is the most common procedure performed in the United States for weight loss surgery. We know gastric bypass, which has been around for 60, 70 years. But we don't know much about the SADI procedure, which came from the duodenal switch. The duodenal switch is an old procedure which combines a sleeve gastrectomy with intestinal bypass, so there's a restricted and malabsorptive component, and it causes severe weight loss. The issues with this switch in the past were the technical difficulty of performing the surgery, combined with metabolic issues as well as GI issues. And so this surgery was never really popular, although it had statistically the highest weight loss of all available bariatric or weight loss procedures. Because this surgery is very effective, doctors were thinking of how to improve this procedure and make it simpler, easier to perform with similar results. And so what we have today is the SADI, which is the single anastomosis duodenal intestinal bypass. It combines the sleeve gastrectomy together with intestinal bypass, but unlike the duodenal switch that requires resections and multiple anastomoses, this procedure only requires one anastomosis of the intestines to the end of the sleeve that gets transected from the first portion of the duodenum. We identified the ileocecal valve, mobilized approximately 300 centimeters of bowel, and anastomose it to form a Greek omega. So the sleeve combined with this anastomosis bowel, people lose weight. But diarrhea is still an issue with the surgery, unlike with the bypass. So the question is, what surgery is better, the bypass or the SADI? So the bypass has inherent issues such as marginal ulcers, internal hernias, which the SADI does not. The SADI does not have internal hernias because there is no cutting of bowel. The SADI does not have marginal ulcers because it is a sleeve, but the SADI is associated with reflux. And so a patient who presents with reflux, the SADI is not a good option, and the bypass is still a very good option for those patients. Also, statistically, it's shown that there's greater conversion of the SADI procedure to other procedures due to diarrhea. So either conversion or reversal. So patients do still complain of diarrhea. So it's very important to make sure that the distal limb of the SADI is no less than anywhere from 250 to 300 centimeters. Anything less will increase GI symptoms significantly. Many studies, even from 2015 when the SADI was not available, but the duodenal switch was, and patients who would perform the sleeve but then either stop losing weight or regain weight, converting them to a duodenal switch versus a bypass increases their overall weight loss. After a median of 42 months, there was an estimated weight loss of 75% with the switch versus 44% with the bypass. And of those patients who were converted due to insufficient weight loss or weight regain also showed greater weight loss with the switch as compared to a gastric bypass, but that was not enough to make the duodenal switch popular due to the difficulty technically as well as the metabolic issues. Dr. Cottom is a well-known SADI surgeon from Utah. He has multiple studies. One of particularly is a 437 patient in a single center trial after 4 years, with showing that 97.6% of patients who underwent the SADI procedure were able to maintain their hemoglobin 1AC less than 6%, plus or minus diabetic meds, and only 8 patients required reoperation for limb lengthening. When we say limb lengthening, what we mean is to increase the common channel. So, for example, if the patient had 250 centimeters of bowel, we mobilized an additional 50 centimeters of bowel to increase the length of the common channel, to decrease the manifestations of diarrhea and metabolic issues that can occur with these surgeries. So these limb lengthening have to do because of diarrhea and hypoproteinemia. And again, in a gastric bypass, these are problems that rarely happen due to the limits of how much bowel you can mobilize in a gastric bypass. There are different studies that show different lengths, but when I was training, we used a 50 centimeter biliopancreatic limb, and we used the maximum 150 centimeter root limb. Sometimes we went up to 160 centimeters for an extended bypass, but we rarely went beyond 160 centimeters for a ruling, and that really clinically did not show any hyperproteinemia issues or excessive diarrhea issues or excessive metabolic issues. SADI, again, very low complication rates with SADI. Centers that perform SADI readily say that it's a very safe surgery. Patients tolerate it for the most part very, very well and have minimum issues. Out of 1,328 patients in a multi-center retrospective review with multiple surgeons, multiple centers over a 6-year period, complications are very low. As you see in the SADI segment, things like leak and volvulus, leaks very low. Volvulus, again, doesn't really exist because there's no cutting of bowel. Internal hernias don't exist because there's no cutting of the mesentery of the small bowel. Ulcers, very rare or don't exist. Strictures, not common, can occur at the gastroduodenal anastomosis. Ileal anastomosis. And bile reflux. Reflux can be an issue. And so again, patients who have reflux, SADI is not a great option for them. Gastric bypass is still gold standard. So, sleeve gastrectomy, again, most common procedure done in the United States. 70% of weight loss surgery in the United States is the sleeve gastrectomy, but it can be used as a segue to other procedures or a standalone surgery. It can be converted to the gastric bypass if necessary, if the patient has severe reflux after a sleeve, or it could be converted to a SADI if there is no reflux and the patient wants to lose more weight but does not want the gastric bypass. The SADI or the single anastomosis duodenal bypass is a good option and is an emerging procedure. Things like gastric banding have fallen out of favor, although it's still performed. Any foreign object that's placed in the body will form a capsule around it, and that causes strictures, and that was the issue with bands. Up to 40% of bands had to be reoperated on due to stricturing or slippage or reflux. So the band, although has fallen out of favor, is still available as an option, but is not readily promoted in the United States. What about other procedures addressing needs that are unmet? Well, we've heard of the gastric balloon. We've also heard of the endoscopic sleeve gastrectomy. There is an emergence of a single anastomosis gastric bypass as well in other countries outside the United States, with the advent of pills and injections also are used in obesity. And so the interesting thing is that the future of obesity medicine is going to be a combination of surgery with medication and other procedures, such as in the treatment of cancer patients that have neoadjuvant and adjuvant treatments. So we can't neglect the fact that medications are a very important component of our armamentarium for the future. Although maximum weight loss with medications is less than surgery, they will be used. Together in the future and used now. Endoscopic sleeve are also performed, but the thing about the endoscopic sleeve is that they do not touch the fundus in the endoscopic sleeve because of its close association with the short gastrics, and tethering on the pouch of the fundus can cause tearing of the short gastrics and has been shown to cause bleeding post-procedure. So GI doctors will not touch the fundus, but in the bariatric surgeons always remove the fundus in sleeve gastrectomy. And so my opinion is that endoscopic sleeve surgery procedures are not as effective as the surgical part because of that fundus being left behind in the endoscopic procedures, as well as those suture ripping. And of course, insurance doesn't cover it, so it's an out-of-pocket expense. Balloons have not seemed to take off as much as we thought they would, again, because they're not covered by insurance. They're limited because of only for 6 months, and then when you take the balloon out, the patient will regain weight, and so they're not very readily available or as effective as we hope, and are very expensive to be placed. Studies in the past placed these balloons for free, but what's interesting, when patients came back to remove their balloons, they were charged money to have those balloons removed. So it's kind of interesting that they were put in for free, but it cost money to remove them. And some of these patients have walked around with these balloons for years. They have them in their bodies. So those balloons are not the best. They can be inserted endoscopically. There's also a pill form of it, which is not approved in the United States because you could imagine drunk college students, testing each other how many can swallow more of a balloon pill than others. So this is not a great idea to have out there in the community. In summary, obesity will impact nearly half of Americans within 14 years. Chronic conditions increase with obesity. Obesity is responsible for many comorbidities and significant levels of mortality. Obesity raises medical care costs, and as little as 5% reduction in BMI can improve health and decrease healthcare costs. Thank you.
Expertise on the latest update on metabolic bariatric surgery. Really, your presentation was very enlightening, thought-provoking, and impactful. And there are several questions coming up, and then I will try. We have at least 10 to 15 minutes to discuss. The first question actually was, since we have been doing sleeve and gastric bypass, and there are two operations which you have mentioned about SADI, single anastomosis, duodenal and duodenal switch. How you think about the future of SADI's operation in New York City itself? Will it replace gastric bypass, or will still remain the same as few percentage of people getting this operation done?
As I mentioned, you have to consider the individual patient. A patient with severe reflux disease or Barrett's esophagus is not a candidate for SADI, and the bypass is the best treatment for that. A patient who had a sleeve gastrectomy but does not want to have a bypass for personal reasons or what have you, they don't want to have as much restriction in their food as there is with potential bypass, can be a candidate for SADI. To promote SADI over bypass, that I think has to do with surgeon comfort, surgeon experience with either procedure. And one thing about the SADI can be converted to a gastric bypass if necessary due to reflux catheter procedure. So there's still room for other things. But ultimately, the SADI procedure will be promoted by the physician and not really pursued by the patient, because it's clinically doesn't have much of a difference for the patient. But we do know that technically we do marginal ulcers and internal hernias don't exist with SADI, so that really is great for the surgeon who doesn't have to get a call in the middle of the night to do that internal hernia. So I think that it will depend on the clinical practice to decide which surgery will be promoted over the other.
In my practice working at New York City here is that I personally don't impose any particular operation on any patient, because most of the patients comes to me, they have made the decision itself, whether they want gastric bypass, whether they want sleeve. For example, yesterday, 18-year-old kid came for surgery, and she came with the main plan of getting gastric bypass. And the mother got sleeve gastrectomy, and she lost several amounts of weight. And her BMI was 55. Her mother came down to 35. But the kid was very adamant, very focused in gastric bypass. So in your practice, do you really go what the patient decisions are, or whether you try to sell any particular operations to them? How do you go with the practice?
Absolutely. I do allow the patient to make the decisions on the surgeries. The point I was trying to make that most patients are not well aware of the SADI procedure just yet, and so not many will come in asking for that specific procedure.
Another thing I must say that, you have to know your area where you're working. You can't offer an operation which will be nightmare for you as a surgeon to deal with and a patient itself. There are a lot of patients, they cannot afford multivitamins. And we go to the big conferences, we talk about SADI, duodenal switch, and we don't look patient as overall who cannot even afford this, 2 times a meal here. And they're talking about multivitamins and all this, post follow-up and all these things. So we, as a surgeon, we have to really focus and know the patients very well before we go ahead and do the operations, which operations. Another question they're asking is that, and it's been very common because there are a lot of physician, medical doctors are also watching this meeting today. They're talking about, will G1P1 replace bariatric surgery like Ozempic, Saxenda, Wegovy. There's so many medications coming up right now in the market.
Well, first of all, we don't do enough bariatric surgery statistically to show that it is less or more effective than particular medication because, again, we only do about 200,000 cases a year. But up to now, medications, you can lose up to 25% of your excess weight, whereas with surgery, you can lose up to 70 to 80% of excess weight. So statistically, surgery is still more effective and will be more effective for those patients who are supermorbidly obese or morbidly obese overall. Surgery, medication definitely has a role in weight loss that can be used preoperatively in patients who don't qualify for surgery due to being severely overweight because of the limits of the CAT scan in the hospitals or what have you. So there's definitely a role. But I don't believe that medication at this point will completely take over surgery. Also, medication use statistically is being shown to be used for no more than 2 years because patients do not like the side effects, the nausea, the vomiting, the burps, the sulfur burps, and the constipation. So there are manifestations of these medications. And I'm not sure if their side effects or actually the medications are meant to do these things. So the patient has to feel these things for this medication to be effective. And they get tired of feeling that way. So these medications are not being used for life terms such as cholesterol medications or blood pressure medications that have no manifestations symptom-wise. So these medications I do not think are going to replace bariatric surgery.
Now, you are correct, Dr. Barkan, because I always tell the patient that obesity is the chronic disease like blood pressure problems, diabetes problems, and there's no one particular treatment that people think come to us that, oh, surgery will do all the magic and they're going to lose and sustain that weight loss. So I always tell that the three important principles. One is the operation, which is going to have a major impact, 60 to 80% of excess body weight. But the two important things is a diet control and active lifestyle. And I've seen people do exercises, and patients comes to me, doc, with a BMI of 60, and telling me you want me to go to the gym. So they get offended also if you talk straight away that you need to go to the gym and do exercise. So we always mention about active lifestyle. So what we do at Harlem Hospital is that we have the medical obesity also there. And if the patient comes with a higher BMI, we basically treat with the pre-op medications like Ozempic, if they can get Saxenda or Wegovy, and then we offer the operations. And post-operatively also, we marry with the medical, medications and continue with the further treatment because surgery itself cannot do a magic job. Another question is because bariatric surgery has becoming more common, and then how do you deal in your hospital like bariatric complications? Like if the patient comes to you, do the general surgeons able to handle the complications, or you have to have a bariatric team who can handle the complication? Because MBI's QIP requirement is that you need to have if you have a center of excellence, you need to have a bariatric on call surgeons to manage it. But some hospitals, they migrate if you do the operation and go to other hospital which they don't have bariatric surgery there. How you feel like are the general surgeons fully educated to handle our complications or not?
Well, I think that up to now or in the recent past, general surgeons did not want to take care of bariatric patients for multiple reasons. One is inexperience with the procedure. Second, with the litigious environment around bariatric surgery and complications. So general surgeons did not want to get involved with patients who had issues after bariatric surgery. But I do believe that a hospital should have a bariatric surgeon on staff covering the hospital if they perform bariatric surgery, because there are nuances, like in every specialty, that a bariatric surgeon will know over a general surgeon due to their experience and know-how and what they've seen in the past. There are hospitals in rural America and many counties in America that do not have even available general surgeons, let alone bariatric surgeons. So in those areas, general surgeons probably take care of some of those issues. And as well, trauma surgeons and acute care surgeons do have a lot of experience with disasters in the abdomen. And so a perforated ulcer, a margin ulcer in a bariatric patient can be treated as a perforated duodenal ulcer or bowel obstruction from internal hernia can be treated as another small bowel obstruction from different adhesion reasons. So general surgeons can handle these issues, but it's better to have a bariatric surgeon available who can maybe do this laparoscopically, who's less afraid because they have more experience with minimally invasive surgery compared to a general surgeon, what have you. So it's probably a good idea to have a specialist on board.
Yeah, there's another question actually from Joshua Merman, and who is a leadership in our International College of Surgeons, also the American College of Surgeons. And his question is, since behavioral therapy is an essential part of weight loss strategies, what is the best option for patients with obesity associated with Prader-Willi syndrome? Is bariatric surgery even an option?
No, bariatric surgery, in my opinion, is not an option for Prader-Willi syndrome patients because they do not have the ability to understand the need for behavior modification after surgery. I don't believe that bariatric surgery is an option for Prader-Willi syndrome patients.
Okay. And another question is that what do you think obesity is more of genetic versus environment, or nature does play a role? What is main component here?
So genetics definitely plays a role. You know, we in medical school we all studied the thrifty gene of the gene of the Pima Indians, and we found that in those Indians, for example, we compare Pima Indians of Mexico and Pima Indians of America. The Pima Indians of America are more obese than the Pima Indians of Mexico because of the hunter-gathering kind of the lifestyle that maybe the Mexican Pima Indians in the past had to live, as opposed to American Pima Indians. So genetics is a huge component, as well as we showed homozygous twins have a higher obesity rate as opposed to heterozygous twins. Genetics definitely plays a role, but environment is just as important. If you place homozygous twins in different households, you could see that there's a difference in obesity. So genetics is important, but environment is, I think, just as important.
Right. And what about gastric band? If I was in NYU, and basically Dr. Fielding had started with the gastric band, and it was very, very common and was all across the world. And in fact, he was who was pioneered it, and he himself got the gastric band. What is the future of gastric bands? I have not done it. I have been removing left and right. Have you done gastric band before?
We've done gastric bands. When I was a fellow in 2006, studies already coming out of Europe by Himpens showing that the gastric band wasn't effective. And they didn't catch up in the United States about 10 years later. Currently, we don't perform gastric bands. We take most of them out. But there are companies that still promote the gastric band, and maybe there is some need for it in certain conditions. But the gastric band has fallen out of favor because of overall its weight loss capacity is less than other procedures, as well as complication profile is pretty high. Like I said, up to 40% of patients have to be reoperated on for different reasons: port displacement, infections, slippages, what have you. So the band has not been as great as initially sold to us.
Okay, and then I'll think one more last question. It's actually one of the medical students who is also a patient, and he's asking that do patients who undergo bariatric surgery have to be on lifetime iron supplements and vitamins? And are the supplements sufficient to bring the iron and vitamins to reference ranges?
Well, the answer is yes to vitamins. Iron, it depends on if the patient is a female or male with menstruation, which can add to iron deficiency. Some female patients will require even iron transfusion therapy after bariatric surgery. With the use of iron pills, that anemia can be decreased and maybe even brought up to normal levels. In males, anemia can be an issue, but not as much as in females due to lack of menstruation. So most of my patients do not take chronic iron, but all our patients do have to be on lifelong multivitamins.
Thank you very much, Dr. Barkan, for your time. And it was very interesting, very exciting and thought-provoking discussion. And once again, from your busy schedule, you came away, on virtual. And I'd like to invite our Brian Donaldson, who is the chair of surgery and who has been instrumental and in shaping the success of our bariatric department. And his commitment to the patient's care, and his dedication to address our concerns is enormous. And he has truly made a significant impact on our team and the patients we serve. So Dr. Donaldson, please come and give us a concluding remark.
Good afternoon from New York City, Harlem Hospital. I just want to thank Dr. Sharik for getting this webinar on the internet and spreading this information to the world, bringing Harlem to the world. I'd like to thank Dr. Barkan for a great informative discussion on bariatric surgery, both the medical and the surgical aspects of it. I think we all learned something today. Historically, Harlem Hospital has always been on the forefront of the treatment of obesity and obesity-related disorders. We started way back in the 90s with open surgery for obesity, with the vertical banded gastroplasties and open gastric bypasses. We have progressed to laparoscopic treatment of obesity. We also provide medical treatment of obesity and nutritional and behavioral modification for obesity. And we also do robotic surgery for obesity. I just want to thank everyone who attended this webinar. I hope we all took something from the discussion. The questions posed were very helpful, and I myself have learned a lot from this discussion. We would love to continue this program, and to close, I'd like to thank Dr. Sharik for having this webinar being hosted by our facility. So thank you all for attending.
Thank you, Dr. Donaldson, for your continued support to our department. And we'll continue this bi-monthly webinar, which will be live. And our next talk will be on body contouring after bariatric surgery. So stay tuned. It will be in September. And then everyone who has registered today will get a CME awarded. And there is a link which you need to follow how to get the CME, and it will be awarded by the International College of Surgeons. Once again, thank you very much for staying with us for an hour, and have a very good day, and God bless you all. Thank you.